Okay, dear colleagues, welcome. It's my pleasure to open today's Level Up session dedicated to COVID-19, vaccination against it, and interactions with urticaria and angioedema problems. I would like to take a moment to be polite and to take a moment to introduce myself. My name is Daria Fomina, and I'm a head of Allergy Immunology Center, certified as UCARE, ACARE, and EdCare team centers. And today it's my honor to present the faculty members who are on board with me today. And I will start with the most active UCARE colleague. It's Professor Emek Kocatürk. I was practicing to pronounce the surname just before the session. Hello, Emek. And Emek is
very well done. Thank you.
Emek,
great pronunciation. Thank you.
Yeah, hello, and Emek is the senior physician from Istanbul, Turkey. Today, I would like to welcome Hanna Bonnekoh from Charité Berlin team. Hello, Hanna.
Hi.
I can't see you through the screens, but still, hello, hi.
Hi.
Thank you for joining. And today with us is Esmee van Lindonk. We are from Rotterdam, the Netherlands. Welcome, welcome, Esmee. Hello.
Hi, thank you for the introduction.
And just sorry, I need to change the slide and cope with this. Yeah, just to remind briefly, and I will definitely ask the help from Emek to remind you some details concerning the UCARE LevelUp program. So in the course of our interactive meetings, we provide the updates, issues of guidelines, new diagnostic and updated treatment algorithms with, of course, with focus on the most severe and challenging situation in dealing with urticaria and angioedema. And of course, the main message is to stay together, with each other and with our patients. And we urge you to spread the awareness of UCARE network and be extremely active in the discussion and during these sessions. Emek, any comments?
Yes, as you said, this is an educational program for physicians. We want to increase the awareness and knowledge, and we try to help physicians if they have any questions unanswered on the management of chronic urticaria. So we have a lot of different task forces. Maybe you can see it on the other slide.
Yeah, there are plenty of formats. Yeah. There are plenty of formats.
Yes.
For the activities, so you can see the schedule of the upcoming ones and those who were already settled. So, and if you want to dive a little bit more into details, you can see the QR code. I have a QR code. I have tested it. It's working. So you can proceed with this one. And the geography is amazing. We have more than 20 countries involved, and we are expecting more. So be active, join the UCARE team, and you will be on this map. So I think that those who are dealing with the urticaria or urticaria and angioedema patients face some challenges during this pandemic. And many questions are still open and they don't have the answers. And I think that we as a practical physicians and scientists will be the ones who someday will get the answers. But today we're discussing maybe the most sharp ones that we can postpone for the future. So Hanna, Esmee, join us with Emek for the discussion, and I just want to remind that we are expecting audience to be really active and to share the questions, comments with us. So you have chat that you can use. Please be open, and maybe your comments will be more valuable than our answers. So happy to be on, to have you on board today.
We are looking for the questions. Yes, we are ready to answer them. We have very good answers, Daria. I guess we do. I hope we do.
I hope we do.
We will see.
Concerning COVID, I'm not so, it's not so, in the COVID pandemic, we came to the conclusion that it's not so nice to make prognosis. We never guess. So.
Yes. At the beginning, it was very complicated. Now, at least we had some experience, and many experiences are shared. We had many publications, but still many questions are unanswered. I hope we will get answers soon.
Yeah, so maybe we can start with the first question. So it's just a very general one. Maybe Emek, you can start. So we want to know what happens when patients with chronic spontaneous urticaria gets a COVID-19 infection. So just a very general one for starters.
Yeah, this was the top question we received at the beginning of the pandemic. The patients were always asking, the physicians also were asking, we were asking to each other, what will happen to our patients? Will we stop their treatment? Will their urticaria get exacerbated? So, and to answer these questions, we made a project within the UCARES. It was just at the beginning of the pandemic, so we didn't have a huge number of patients, but we at least had 79 patients included who had chronic urticaria and also experienced COVID infection. And so what can happen to these patients? The biggest anxiety was that the urticaria will get exacerbated. And yes, indeed, this was the case. And like 40% of the patients had their urticaria exacerbated during COVID-19 infection. But the treatment didn't differ between these patients who had exacerbations. So, and this stressed the importance of having treatment, having controlled urticaria during the pandemics. Because if you don't have a controlled disease, then you will have more exacerbations. So it stressed the importance of having good control and having treatment. And the treatments did not make the patients have worse COVID infection. So it can happen, chronic urticaria can exacerbate. Even it can get better in some patients. It was the patients, 7% said that it got better, and it's really,
or even disappeared. Even disappeared. Yeah, they went to the remission. Right. We had this patient who were really severe, and I think that we didn't reach 7%, but like every 10th patient with severe urticaria went better with their course. Yeah. Sorry for interrupting.
No, please.
It was a positive one.
Yes, and it's really interesting what can the immune system and the viral infection interactions with the immune system. It's really so interesting. What happens inside is a mystery, and I would really like to learn what happens there. So, and these were the results of the COVID-CU, and it can exacerbate in 40% of the patients.
I think that we even using simple approach in, for example, without diving into pathogenesis or something, we just can phenotype patients, because for me, it was not clear at the beginning for those who had, for example, severe fever, they started taking the non-steroidal drugs, for lowering their fever. And for me, it was not clear, is it a virus-induced exacerbation, or is it the trigger coming with the drugs, because we know that there is a phenotype of our patients with chronic urticaria that which have the non-steroidal drugs on the list of the triggers of the disease.
Yes, but in the study we checked if they had NSAIDs, and here in Turkey especially they refrained from using NSAIDs because there was a warning that the infection might get worse during if you use NSAIDs. And in the study we saw that if the patient had a worse COVID infection, urticaria exacerbates more. So in the hospitalized COVID infection patients who had chronic urticaria, the rate of chronic urticaria exacerbation was like 70%. So, and in another study, they found that fever also, patients with fever had more exacerbation of urticaria. So it gets more exacerbated with a severe COVID infection.
But I think that they will lower the fever if it's really high. So we can't, or with, for example, with prednisolone or something, I don't know, but still, yeah, we understand that we have to divide these two scenarios from if it's drug induced or if it's virus induced.
Point, yes.
The other issue that we still unfortunately have the patients who are on basic treatment of prednisolone. They are sometimes it's their wish to take it to have, fast relief or something. So, and at the very beginning, we understand that when there is a virus load period, it's not so safe to take the systemic hormones while this viral load period. So I'm just coming to this phenotyping, the portraits of the patient, they're completely different, and using really simple tools, we can maybe answer these questions in the cohort that we are collecting. Yeah, thank you, Meg.
Yes, hope to find answers soon.
So
Okay.
Maybe another question. So in regard to treatment, you talked about the NSAIDs, yes or no, prednisolone. So are there any recommendations, general recommendations for CSU patients who were or who are infected with COVID-19? So what's your experience, Daria?
I think that the main conclusion is important before pandemic, during pandemic, and after that, we need to achieve control and to make this control of the disease stable. So the main thesis is that the patients have to be on their basic effective treatment and not to cancel it and not to create additional risks for losing the control. So at the beginning, the questions were concerning the omalizumab, for example. We had doubts whether to prolong, to stop, what to do. Emek, definitely you remember this worries. But in fact, some answers came from asthma cohort. As you remember, the pulmonologists were allergist immunologists were the first who said, okay, it's fine. Even we can discuss the protective benefit from the anti-IgE treatment. There were some challenging situations concerning not the clinical, but the organizing issues. So it was mandatory to create the schemes how the patients, for example, on biologicals will receive this treatment. That was a very important issue because on one hand, you have risks concerning the coming to the medical department. At the other hand, you have a risk of losing the control of the disease, and some fears were among medical staff, among patients, and of course, some of the online formats of communications became more widely spread along the among the tools to stay online with our patients, to maybe to lower the stress level. That is, and stress is very important as a trigger in urticaria exacerbation.
Yes.
Yeah.
Yeah, they had a lot of stress during the infection, because at the beginning we were really very scared, and there was no vaccination at that time, so the patients were really scared and stressed. So this is one of the triggering factors, as you said.
Stress. And then another stress came with vaccination. Yes.
Yeah. Right.
Multiple ones, yeah. And of course, we should understand that I think that a big limitation that we see in the studies now, that we don't assess the spectrum of the comorbidities in the right way, because we know the comorbidities which are strictly tied to the severe cases of COVID. And in those publications that I met in PubMed or are appearing now on the in media, still we are focused, like disease-specific issues, not on the spectrum of comorbidities, because the patient with urticaria can have autoimmune or any other problems that can be plus or minus in the future risks of exacerbation, losing control, or whatever.
Yeah, they have other allergic conditions.
Other allergic conditions, of course.
But in the, I think it was the reason the infection was mild in chronic urticaria patients is that the patient cohort is more female. 70% is female, and the age range is like 40 years of age. So it's not a very risky population for severe COVID. So it's one of the advantages, of course. But in the COVID CU study, I think 20% of the patients had hypertension, which is also a risk factor for severe COVID. So they didn't have a severe infection despite having hypertension as a comorbidity. But
in fact, the inflammatory markers, for example, some of them like high D-dimer, I'm just wondering, can influence the course of COVID. We know, like high dimer is a risk factor for severe COVID, and our patients with urticaria, we have an approach to phenotype them, biologically phenotype with this marker. Maybe it can be an indicator for dividing them in subgroups, because we still see that in some cases and in some studies, the numbers or the prevalence of the chronic spontaneous urticaria patients who experience the severe COVID is pretty high, in fact. But yeah, maybe because of some inflammatory markers such as CRP, what we see sometimes we see elevated in our patients, maybe D-dimer or yeah.
Yes, every patient is different. So
because in some studies I saw that yes,
I think is really important. Yes, of course. And do you have other questions?
Yes. I wonder if CSU patients need intensive treatment more often. Do they have more complications? Do they need specific treatment more often?
During COVID infection?
Yeah, during a COVID infection or maybe after.
Okay. Actually, I don't think that this is the case, because it's the most important thing is to keep them under control and to continue their treatments. But coming to treatments, shall we stop immunosuppressive? Shall we stop omalizumab? Shall we stop antihistamines during an infection? This is the, I think, major issue that we need to deal with. The guidelines actually depends on experienced physicians' opinions. So they are not based on double-blind, placebo-controlled, evidence-based studies. So the approach is like, of course, we need to continue their antihistamine treatments. And for omalizumab treatment, it's really taken as a safe treatment during an infection, actually. But if the infection is severe, then we need to withhold the treatments unless the patient is symptom-free. Like in 2 weeks, we can reconsider using it again. For immunosuppressives, like cyclosporin A, we need to withhold the treatment again. For the systemic corticosteroid, it's not so easy to abruptly stop the treatment, but we can gradually decrease the dose, but not to, of course, we shouldn't lose control of the disease. Usually we don't want to use systemic steroids during the treatment of chronic spontaneous urticaria, but sometimes it's needed, and it's not recommended to stop the treatment abruptly, but to the lowest dose possible. So these are important, but I don't think that chronic urticaria patients need a special approach after COVID infection, but we need to consider that it can exacerbate, and we need to calm down the patients and tell them to keep on their treatment.
Emek, do you think that in some, for example, situation when the patient exacerbates during the COVID or during the symptomatic period, it's logical that we will escalate antihistamines? It's logical. And do we have a right to initiate, for example, OMA? So we have a portrait of the patient.
Actually, we can do that. But if it's a severe infection, I would be a little bit cautious, because there are case reports who said you can use it in exacerbations due to COVID infection, but there are only, I think, 2 or 3 cases. So I would be cautious, but would use if needed. But I may personally prefer to use very short-term corticosteroids in this case, and would start omalizumab after the COVID subsides, because steroids for short-term is not very bad for the, it doesn't cause immunosuppression at first doses. It causes in the long term. Causes immunosuppression.
At the initial stage of the disease, it's not so safe. The corticosteroids, it was proven in some studies. So we, for example, for indication of COVID, we have strong recommendation that we need to initiate systemic glucocorticosteroids only if we have the features of the respiratory problems. They have severe respiratory problems with the lowering the level of oxygen, and that's it. Yeah, but still, it's
and benefits. So we need to be cautious every time. It's always risky.
because I have an experience with one patient who was hospitalized, who never experienced the symptoms of urticaria, and the onset was sharply during his COVID, and he was severely ill. The patient was middle-aged, like 45 or around, and after 4 weeks, it's still acute phase, but the symptoms were accompanied by severe itch, multiple coverage of the urticaria on the surface of the body, and the angioedema. So in 4 weeks, no response to antihistamines, very short in hour. I could even count in hours the short period of the effect of the glucocorticosteroids. So I initiated omalizumab.
Yes.
And succeeded.
And it's
so
really
it's like
off-label,
but
it really clears out everything.
On the needle, right? Yeah. Yeah.
Yes,
we have some questions from the audience.
Of course, we have. I didn't notice. Sorry. Yeah. Go ahead.
The first question is, how long do patients have to wait to take an OMA shot after COVID-19 infection?
Yes, they can start 2 weeks after their symptoms. If the PCR is positive, then you can start after 2 weeks of PCR positivity, or if the symptoms started, you can symptoms start and 2 weeks after symptoms starts. And if there is resolution of the symptoms, you can start in 2 weeks.
Okay. And the next question is, which COVID vaccine are the safest for CU patients?
So I think we will come to these points later. So let's I think we need to hurry up a bit because I think we have only 15 minutes.
So I think we've got the last question in regard to the COVID-19 infection, and then we can switch to the vaccine questions. So the last question would be, so because, you know, when we're working in the emergency room, we saw a lot of patients with acute urticaria, and this was the first symptom of COVID-19. And now our question is, and maybe you can answer this one, but I'm not so sure. So how many patients get acute urticaria after infection and eventually also progress to CSU?
Yes, that is the burning question, isn't it, Daria?
Yeah, a bit challenging because we don't have the evidence, only our clinical experience, that's it. So of course we will share it, but no reference, no publication concerning this issue, the transformation from acute to the chronic, the chances, the percentage. So we don't have numbers. But we have, in fact, both portraits who start with acute and stop with acute, and those who proceed. In my experience, those who had really high inflammatory markers during COVID, they crossed the border of 6 weeks. That was my experience, but no evidence, just experience. And the other thing that I have few patients who had autoimmune thyroiditis, high numbers with anti-TPO, really low IgE level, and they crossed the borders. But one went to the remission in 2 months, and the other proceed with the escalation of the treatment. So that's my really...
That's great experience, Daria. I would also comment like this, because we all know that viral infections cause acute urticaria. This is a common textbook information. So, but we don't know who progressed to chronic urticaria, because when we check for causes of chronic urticaria, we don't find any viral infections causing chronic urticaria. So we only talk about bacterial infections, Helicobacter pylori, or parasitic infections. So we don't speak about viral infections. But I agree with you that the patient with an autoimmune basis, they tend to go to chronic urticaria after
maybe
after
this virus infection
or
was just
after viral infection. Yes. Let's skip to the next question.
we don't have predictors now, but we need to.
Yeah, so we've got also a comment from Anna in the chat, and she also reports that it's common from her experience that this is happening, but there's no publication, and she sees it in COVID patients as well as after vaccination, that there's chronic spontaneous urticaria arising. Okay, so I think maybe we can.
Anna, hi. I want to say
maybe we can switch now to the.
Okay, we became more nervous after such supervision.
Okay,
yeah, I think
Esmee,
we're all
maybe.
very
Yeah,
curious
perfect.
about data from the COVID UCU project, Emek. So is the COVID vaccination, is it risky for CSU patients?
Yes, this COVAX-EU study, that the main question was that, because patients were asking, I don't want to get vaccinated because it will cause my urticaria get worse. I will have an allergic reaction. So we asked, is it really like this? And then we started the project, and we really have a great number of patients, thanks to all the participants, for the supporters, all of you participated. Thank you so much. So we had like 3,000 patients, and main findings are now advertisement. Okay, we had, I think the patients had 16% of urticaria exacerbation. And it was not a really big frequency of exacerbation from my point of view, because we saw that exacerbation is more common when patients had COVID infection, but it's lower and when they had COVID vaccination. So it was really assuring for us to see this result. So, and from this 3,000 patients, only 7 had anaphylaxis, but we are not sure if they had real anaphylaxis, because it was also written that they had exacerbation of urticaria. So it's really not easy to differentiate between if it's an exacerbation of chronic urticaria or it's an anaphylaxis. Maybe. Yeah, so the study depends on patients' expression. So it's not a emergency doctor defined situation. So we are not sure if they are real anaphylaxis. And it was not, it more occurred in patients with atopic background, like who had drug allergies, pollen allergies, and it was not really common. And these were the findings, I believe. So being a female was more risky to have chronic urticaria exacerbation after vaccination. And also, if you have chronic spontaneous urticaria, then you are more risky versus having inducible urticaria. And other factors, if you are not on treatment for urticaria, then you have more exacerbations of your disease. And it was interesting that if the patient had more concern about having vaccination, then they had more exacerbation of their chronic urticaria.
Yeah.
It's important to calm them down. So to, I think, give them some encourage.
Or any pre-medication? So we need to discuss the pre-medication.
Yes, they
before.
Minority of the patients had pre-medication actually.
So those like anxiety or
Yes, it was not really high.
So as there are so many different vaccine options nowadays, 2 years ago we didn't have this situation. Louis is asking in the chat, which COVID vaccines are the safest for chronic spontaneous urticaria patients?
Yes, okay. With this study, Daria, can I answer this? Sorry for...
Of course, no, go ahead. I'm preparing my cohort from your study, so I am just peeping in, so I will be back with
good to see your results too. So in this study, we saw that Moderna and AstraZeneca vaccines had more exacerbation risk, but we really don't know why. And the Sinovac vaccine had the lowest, but you know, it doesn't provide a lot of benefit to. It doesn't provide a good coverage for COVID infection too. So it's like no pain, no gain. I don't know. So these were, and I was guessing that BioNTech vaccine, Pfizer vaccine would lead to more exacerbation, but this was not the case. And most of the patients had BioNTech vaccine in our study. Most of them had 2 vaccines, but some very minority, I think 27 patients had 4 doses of vaccines. And if they had exacerbation at the first vaccine, like 1/3 of them did not have the second vaccine, and others had second vaccine, and half of them had urticaria exacerbation again, but only 10% of them had urticaria exacerbation at the third vaccine. So the exacerbations get decrease with the doses. Yes.
So it's like a tachyphylaxis kind of, you know, when you're meeting the antigen, and then you come to kind of exhaustance, maybe exhausting one.
Yes. And one thing I also want to add is patients on omalizumab treatment did not have exacerbations that much compared to patients on antihistamine treatment. So it seemed to have a protective effect against COVID-induced urticaria exacerbation.
But I think it's same scenario with the disease-induced. I mean that the COVID-induced exacerbations. So those who are on anti-IG treatment, like with OMA, they experience lower numbers of exacerbations. Same with vaccination. So we can discuss about the protective potential for vaccine-induced exacerbations and disease-induced exacerbations. Yeah.
Yes.
I also have doubts about the real anaphylaxis, because I think that we need to have this strict criteria for charging these reactions, because they are now a bit flexible, and sometimes if patient has angioedema and rash symptoms, they are considered to be those with anaphylaxis, but some doubts, yeah, still. We discussed this in the frame of, you know, the study of the cold urticaria with Moitza, when we were trying to get the proper criteria for real anaphylaxis in patients with chronic urticaria. Emek, you might remember that one, yeah.
Yes. It's important to differentiate. So, and when it depends on the patient's expression, so it's really tricky.
Now we talked about some complications from the vaccine, but could the vaccine also be beneficial for CU patients?
I think that Emek mentioned that the more you are vaccinated, the less exacerbations you have.
Okay.
Yeah.
But do they get improvement sometimes?
Yeah, maybe.
minority of the patients who said that their urticaria got better after vaccination. I think it was 1% or so.
But it's
Yes,
a great,
happened.
great fear in specialists and in patients to proceed with vaccination after the first exacerbation, after the first dose. That's what we see in our patients. So if a patient experiences exacerbation, they are trying to be more aware of.
Yes, and the exacerbations do not they are not long-lived. Actually, they only take 1 to 3 weeks and then they calm down. So it's not a really long-term exacerbation. So it can be treated and taken under control.
But we just discussed, Emek, the issues of the urticaria exacerbations, but we have the spectrum of adverse events like fatigue, like muscle pain. Do we meet them more frequently during in the patients with urticaria after vaccination in comparison with the whole population?
No, it was similar. It was similar. We saw muscle pain, fatigue, local reactions. Local reaction was the most common one. It was 30%, and the others like 17%, 20%. They were similar to other cohorts.
Yeah, and I would like to make a comment. So we are discussing the active vaccination, and I would like to have a comment on passive immunization. So we have this option with virus neutralizing antibodies which have the prolonged period of protection. So these antibodies now are Roche and AstraZeneca have them. So for those who are after the severe exacerbation or some temporal contra indications for active immunization, we know that we have this periods that by different reasons the patient need to postpone the vaccination. So we have this option, and it's very safe for those patients. So this is the standardized medication, virus neutralizing anti-COVID antibodies, which are really effective, and they cover like 6 months of protection. It's kind of an options for those who don't fit the vaccination at the moment.
Okay. Thank you. So, do we have anything to discuss?
I think Emek, we had one question that we skipped. No? Can Hanna or Esmee help us? No?
Same question with Louis. It was the same question with Louis.
Yeah, it was the question from Louis, which vaccine was the safest?
The safest, okay.
Yeah.
So do we have any other questions?
Maybe some questions from the audience. So now is the time.
Okay.
And about safety, we need, as being an allergologist or urticariologist, how Marcus says, we have some components in the vaccines, like, for example, polysorbate or, for example, polyethylene glycol, these components which are associated with the adverse events. So we just need to keep in mind that we can have some adverse event connected to these components. It's the most common ones, yeah.
We asked if they had such an allergy, but nobody had such an allergy in the vaccine use study. So I think the time is over. What do you think?
So unfortunately, we need to say goodbyes, and yeah, can we have the last slides on, please? Or I can share them, or the technical, or we need the technical support. Okay, let me do that. Okay. And so first of all, of course, sorry, colleagues and the audience, of course, sponsors. Thank you very much for supporting and making this meeting happen. And before saying goodbye, I would like to ask you to please go with the QR code and leave your feedback for us, because it's very important for those who are organizing these meetings and for future programs and for proceeding with such high quality. Thank you very much, dear colleagues. Emek, Hanna, Esmee, thank you for being today and for this amazing discussions. And we are very grateful all together. Emek, I will share the words with you. I just want to thank the audience for being active, for your questions, and for finding time in the summer to be with us. Emek, please, your turn.
Yes, thanks to all the participants, to all my colleagues. Thank you, Daria, for this vivid discussion. It was really nice to discuss these topics, and I learned a lot from you. And thanks, Hanna and Esmee, for participating and being active, and for your questions. We really appreciate that. So thanks a lot.
Thank you. Bye-bye, everybody. Thank you. And we are looking forward for your feedbacks. Thank you.
Yes. And I want to say, please share and like the UCARE LevelUp activities in your social media. It's very important to spread the word.
Okay, just share your cases, share your cohort observational studies with us. And so maybe we'll be more confident in answering the questions. Bye. Bye.
Okay. Bye-bye.
Bye-bye.